So today we're going to be doing a ridge split and or some ridge expansion using Hyosin's ESSET surgical kit, ESSET. Surgical kit that Hyosin came out with about a year ago. It's a fantastic multi-purpose kit for dealing with really narrow ridges. Miss Lawless has a tremendously narrow ridge here. I removed tooth number 31 mid last year, about September or so last year, and it failed because of a furcal involvement. So removed the tooth, grafted it, and the patient has now set. It is now about 5 months. So we're going to go back in, and I'm just going to free up that gingival tissue a little bit. If you have any pain at all, you let me know, okay? I do not block my patients when doing dental implants at all. I don't find it's necessary. So I gave her buccal and lingual infiltration using Septicaine, Articaine. All right, we can see she's got a really good ridge shape, really mature bone. There's a little bit of fibrous tissue right there, but you can see how narrow that is. And we are talking about the molar area, 30 and 31. So we're going to have to work with what she's got. And I'm going to do a little bit of ridge expansion using the ESSET kit. Also, what you can't see is that there is actually an undercut about 5 millimeters down on the lingual, and that has me concerned. That is where the lingual artery would sit and the lingual nerve, so we don't want to go anywhere near that. That could cause undue bleeding and problems, so we're going to stay away from that. Let me go this up right down the buckle. All right. Okay, included in the ESSET kit are these, it's a ridge saw, so what it does is it's going to go right down the top of the ridge, and it's going to allow me to trough an area that I'm going to come back later and expand. So we're going to go ahead and start that. There we go. That gets right through that buccal plate really quick, faster than in piezotomy, which is why I prefer this now. We've got our line scored, and you get 3 different sizes of these saws. So this is the medium, and I'm going to switch over probably to the small, and I'm going to make a releasing cut as well. Now, if her mandible was jaggedy or had a lot of ridges to it, they also have a modifying burr that we can use to flatten the ridge a little bit. I do use that a lot. It's one of my favorite burrs to go to actually for this. So just right up in here, I'm going to get a quick releasing. I'm not at an ideal angle here, but that's okay. And now we're going to start our osteotomy. So we've got our 2 osteotomies. I am going to give her a premolar and a molar when I'm done. Originally I was just going to give her a molar and then connect the natural tooth using a stress breaker, but because Miss Lawless has been so kind to let me videotape this, we're going to go ahead and give her 2 implants. We're going to give her 1 for free actually today. And then we can start expanding that ridge. You can see on the buccal, there's an undercut here as well, but I haven't penetrated that space, so we're just going to expand that ridge, and we're going to get 2 decent-sized implants in there today, which would be really nice. The next burr in the series I'm going to use, this is the 2.2 millimeter osteotomy. I'm just going to widen that a little bit, just a smidge. And this is the first of the expansion burrs. It's size matched to the Hyosin ET3 system. I'm going at 25 RPM. We'll just go until that bottoms out, and you'll see the buccal and lingual begin to expand. You don't need water irrigation for this because you're going at such low RPM. And we're not removing any of the patient's bone. This is a great preservation technique. And you'll see that initial line begin to open up a little bit. So we're condensing the bone around the expander. And of course, the other way we could have done this was we could have done a block graft on the buckle, or we could have come in and done some kind of heroic graft using membranes. Hyacinth now makes a titanium mesh system that's fabulous. But in this case, she has really good buccal and lingual plate. So we're going to just expand that out for us a little bit. I don't block my patients. If I'm going to be near her mandibular canal, the inferior alveolar nerve, the patient's going to tell me that I'm near it. That's why I don't block. There we go. So I've got enough room now in the site number 29 for a 3.5 millimeter Hyacinth ET3. So that one's done. And the implant itself will actually hold the osteotomy open when I get that in there. The thread is almost perfect for this. Where number 31 is going, I'd like to get that open to about a 4.0. So we're going to do one expansion using the 3.5. As you can see, here you go, that just bottomed out. We're getting really good contact right there. And again, realize I haven't removed any of the patient's bone at all. So we've just condensed it around that osteotomy. And again, I'm done with the front osteotomy, which is number 30, and we're going to go ahead with number 31. I'm going to do one more condensing. And this will bring me up to a 4.0. I just received last week a new implant from Hyacinth. It's still an ET3, but it's been HA coated, and so we're going to put that in there. So we have a, you can see there's no fracturing of the buccal plate or the lingual plate, so we're going to go ahead and put a 3.5 by 10 in the area of number 30, and I'm going to put a 4.0 by 10 in the area of number 31. Okay, this is the 3.5 ET3 by 10 millimeters. We're going to go ahead and thread that in there. You see the buccal will give us a little bit of movement, which is fine. Remember, I made a little bit of a reliefing cut there. This is a 4.0 by 10 ET3, HA coated, brand new coating from Hyacinth, which really has me kind of excited. We're going to take our carriers off at this point. Whenever we do a procedure like this, you always want to countersink the implant by about 1 millimeter to 2 millimeters. You're going to go a little subcrestal with it. That's because we know we're going to get a little bit of dieback just in the procedure. This is not because of pressure necrosis. In order to achieve pressure necrosis, you have to exceed 125 Newton centimeters, and we are nowhere near that. The machine is set at 50, so we're half that. So I'm going to sink that just a little bit. And this is their hand driver, and that line is at 3, so we're going to set that just to 2, which is right there. The 4.0 now. I'm going to put healing caps on both of them. You can now see the tops of those implants. The 4.0 is countersunk about 1 millimeter, and the 3.5 is countersunk by about 2 millimeters. I am going to come in and put a little graft material on the buccal of number 30. Just to protect, we had a little bit of a fracture line forming there, so I don't want anything to get in there. So we're going to use, actually, I'm going to put a little bond bone there. That's a product by MIS. We're going to mix that up, and you'll get to see us put that down as well. So I put my cover screws down. The green is the Hyacinth standard size, which is everything from 4.0 all the way up through their 7.0. The purple, anodized purple that you see there, that's their mini, which is the 3.5. So it's a slightly different color for them. And I'm going to put some bond bone right in here, right in this area here. So first I'm going to make some decorticalizing punches just to get some blood moving through the area. I don't want to just lay that down. I want to actually give her the ability to grab onto that. So we're going to go ahead and do that next. And also, while I've got the bond bone out, I'm also going to add a little bit right into that releasing incision, the cut that we made through the buccal plate, through the cortical plate right there. That will fill that in nicely. Now her clot, she'll form a clot in there and she'll form bone in there nicely anyways, but while I'm here, I might as well do it. So we'll go ahead and take care of all that for her right now. Alright, I've gone ahead and mixed up the bonbone. It comes as a powder. It's biphasic calcium sulfate, mono and dihydrate, which is nice. And it's got a working time of about 2 to 3 minutes. That's up real nice, actually. Just lay it where we want it. Bonbone's got a resorption time of about 4 to 6 weeks. So it's going to hold that nicely while she builds bone into it. Now in my practice, I always mix bonbone with all my grafts. Even if I'm doing PRGF or one of the other techniques, I still mix bonbone with it. I find it does allow for quicker healing. The patients don't seem to mind it, and I get a much better result at the end. It doesn't require the use of a membrane because it actually sets up just like plaster of Paris, which is what it really is a purified form of that. So it actually does set up into a nice solid wall, and it makes its own barrier. If I do a hybrid graft where I'm adding materials together, then I do use a membrane, but in this case I don't really need one. Now today I'm going to suture with silk. My office, I don't use any resorbing sutures. I don't use chromic gut. I don't use Vicryl. I want to be in charge of how long my sutures stay. And I also find that a lot of the resorbing suture materials tend to irritate. In my office, either I'll use silk or I'll use PTFE by Cytoplast. If I'm doing more with membranes, I definitely will use the PTFE membrane from Cytoplast. In this case I didn't have a membrane, so I don't really need that extra step. I always buy high quality sutures. I don't buy gray market stuff. There are problems with some of the gray market sutures. They will stain the gum unusual colors. I'm not really too keen on their sterility. There you go. You can see we've got I'm going to add one more suture right there. We've got nearly 100% perfect closure, totally tension-free. Which is just perfect. She's going to heal beautifully. This is the Acid kit that I was just using on that patient. This is the expander section here, and these are the expanders that you just saw me using. They're color-coded, so you can't mix them up, and you can get all the way up to a 5.0 implant with these if you go all the way up to the largest size, depending on the density of bone. Now, I've used this also in type 4 bone because I can condense that bone instead of taking away what little bone I have, improve its qualities, and still get an implant to be very, very stable. Particularly these tapered implants, the ET3s, they're just so fantastic. These were the saws that I used. They come in a 7, a 10, and a 13. I used the 7 and the 10, as you saw me do. This is the crest modifying burr. This was kind of in the wrong part. That's okay. You can use this, just drive it right along the crest, smooth it out, get rid of any irregularities that are going to cause you a problem later for restorative reasons. I use this a lot. And this is the other crest remover that they give you. I like this if I'm going to do some aesthetic zone contouring, if I'm going to make a pontic design and I want to really make a nice little dimple there for myself. And they also include this crest remover as well, which you would use on a straight nose. I don't have a straight nose in my office, so I never use this, but it is available in the kit as well. On the side, they have all the different drivers that you're going to use. All of ours have been used today, so there's none of that left in there for you. In the bottom, they're going to have the placement wrench, so you can do those by hand. I usually will hand place my implants. I don't usually use the machine to do that. And also, this is their depth gauge. It tells you how far below the gingiva you are when you come back to restore these later. So that's their Acid kit, which I fell in love with about a year ago, and we've been using it ever since.